I'm Dr. Catherin Harris, and I want to begin with one clear truth: sex should not hurt. If you have been telling yourself that pain is the price you pay for intimacy, I'm here to gently, firmly challenge that belief. Pain is not a test of loyalty, nor a badge of toughness. Pain is information. It is your nervous system saying, something here needs a different approach. Today I will help you decode that message with compassion and precision so you can protect your health, advocate for your comfort, and rebuild a relationship with your body that is kinder, safer, and ultimately more satisfying. Let's ground ourselves in the basics. The body experiences many sensations during arousal and intimacy: pressure, fullness, warmth, stretch. Those can be intense yet comfortable when tissues are healthy and well lubricated, when muscles can relax and coordinate, and when the environment feels safe. Pain, however, stinging, burning, cutting, sharp, throbbing, deep aching, cramping, or an immediate clench, is a different signal. It is not something to power through. Your body is not working against you. It is trying to protect you. When you treat pain as data, you gain choices. Slow down, change what you're doing, or get the right evaluation and treatment. There are many reasons sex can hurt, and most of them are treatable. Hormonal changes can dry and thin tissues. Pelvic floor muscles can become too tight or uncoordinated. The delicate skin at the entrance to the vagina can become hypersensitive and reactive. The bladder can be irritable. Infections can inflame tissue and nerves. Deeper pelvic conditions, such as endometriosis, fibroids, or scarring from surgeries or childbirth, can cause deep pain. For men and people with a penis, the prostate can become inflamed, or scar tissue can create painful curvature. None of these realities make you broken or difficult. They make you human, living in a human body that responds to stress, hormones, injury, recovery, and time. With care, most people feel dramatically better. I'd like to walk you through warning signs you must not ignore, not to alarm you, but to empower you. First, if you ever feel sudden, severe pelvic pain during sex, especially if it comes with fever, chills, nausea, vomiting, or an unusual foul-smelling discharge, that combination calls for prompt medical care. Infections of the reproductive organs can escalate quickly and need proper antibiotics and follow-up. Your job is not to diagnose yourself. Your job is to pay attention and ask for help when the signals are loud. Second, if there's any chance you're pregnant and you notice pelvic pain, dizziness, faintness, or unusual shoulder tip pain along with vaginal bleeding, that is not a wait-and-see situation. Certain emergencies present this way, and immediate evaluation protects your life and your future health. If you feel unsafe to drive, call for help and go now. You will never regret getting checked. Third, if you notice bleeding after sex, especially if it's new for you, if it happens repeatedly, or if you're postmenopausal, schedule an evaluation. Many causes are benign, from tissue irritation to hormone-related dryness, but bleeding is a message that deserves attention. If bleeding is heavy or accompanied by significant pain or dizziness, seek care urgently. Fourth, a sharp, burning, paper-cut sensation at the entrance of the vagina with even gentle touch, a tampon, a pelvic exam, or attempted penetration suggests a hypersensitive vestibule. People sometimes get told to just relax or use more lubricant, and while lubrication matters, that advice misses the point if the tissue is truly reactive. The good news is that this pattern responds to a thoughtful plan: calming topical care, nervous system soothing strategies, pelvic floor physical therapy to help muscles release and coordinate, and time. Relief is very possible. Fifth, deep pelvic pain during or after sex that clusters around your period or shows up with heavy cramping or bowel symptoms raises the possibility of gynecologic conditions like endometriosis. This is not just bad periods. Deep ache, sharp stabs, post-sex cramping, pain with bowel movements, and chronic pelvic pressure deserve evaluation by a clinician who takes you seriously. Diagnosis may take patience, but you do not have to normalize deep pain that steals your energy and intimacy. Sixth, if pain is tied to dryness, burning, and irritation, especially during perimenopause and after menopause, that often reflects hormonal changes that thin the vulvar and vaginal tissues and can even affect the urethra and bladder. Moisturizers for daily tissue support and lubricants for intimacy can help, and local estrogen therapies are often transformative for comfort and urinary health. This is not vanity, it is tissue biology, and it responds beautifully to the right care. Seventh, for men or people with a prostate, painful ejaculation, perineal aching, pelvic pressure, urinary burning, or fever may signal prostatitis. Sometimes bacteria are involved, sometimes it's inflammatory and related to muscle tension and nerve sensitivity. Distinguishing the type guides treatment, which can include medications, pelvic floor therapy, and behavioral strategies. If you have fever, chills, difficulty urinating, or urinary retention with pain, seek care promptly. Eighth, for men or people with a penis, increasing curvature with painful erections or penetration difficulties could indicate scar tissue forming in the erectile tissue. Early evaluation matters. Therapies range from watchful waiting to medications, injections, and surgeries in selected cases. What you must not do is suffer in silence. Having a conversation with a clinician can open options and protect your sexual function and confidence. Ninth, if you sense your body locks up when you anticipate intimacy, or you feel a tight ring of tension at the entrance, or you notice clenching in your pelvis you cannot think your way out of, that points to a hypertonic or guarding pelvic floor. This is incredibly common. Muscles that once protected you from pain, stress, or trauma can get stuck in on. Pelvic floor physical therapy is gentle, private, and paced to your comfort. These professionals teach your muscles how to lengthen, coordinate, and release. This is not about pushing through, it's about retraining safety. 10th, burning bladder pain, frequent urination, and pelvic pressure that flare with intimacy may be a straightforward infection, or you may be dealing with a chronic bladder pain syndrome without infection. Either way, thoughtful evaluation prevents unnecessary antibiotics and guides a plan that reduces flares and restores comfort. Now, I want to describe what good care looks like so you can recognize it. A quality evaluation starts with time to talk. Your clinician should ask where the pain is: on the skin, at the entrance, deep inside, around the bladder or urethra, what it feels like, what triggers it, and what calms it. They'll want to know when it started, whether it coincides with your cycle or life changes, whether there was a specific event like childbirth or surgery, and what medications or products you're using. They will ask about lubrication, arousal, and positions. Not to judge, but to understand the mechanical and muscular context. If trauma is part of your history, you should be offered trauma-informed care, explicit consent for each step, the option to stop at any time, and a plan that respects your boundaries. Examination can be minimal and gentle and still useful. Sometimes a swab rules out infection. Sometimes a urine test checks the bladder. Sometimes imaging investigates the uterus and ovaries. In many cases, pinpointing the pain with a lubricated cotton swab at the vestibule or assessing the pelvic floor's ability to relax tells the story clearly. If you've ever been told, everything looks normal, it must be in your head. Let me rewrite that narrative for you. Pain is always real. Normal labs or scans simply mean we have to look at nerves, muscles, hormones, and tissue sensitivity with more nuance. That is not a dead end, it's a doorway. Many people improve not because one magic pill changed everything, but because a layered plan addressed each contributor: tissue health, muscle tone, nervous system regulation, and relationship safety. Let's address some myths that keep people stuck. Myth 1 is that lubrication alone solves painful sex. Lubrication is important, and I recommend keeping a good quality, unscented, hypoallergenic lubricant within reach every time, but if pain is sharp, localized, deep, or persistent, or if there is bleeding, fever, or new curvature, we're dealing with more than friction. We need diagnosis and a targeted plan. Myth 2 says, if I just push through the pain, I'll get used to it. What actually happens is the nervous system learns to brace earlier and harder next time. Muscles clamp, fear rises, and pain worsens. We don't bully muscles into relaxing. We invite them to trust again. Myth 3 claims that if tests are normal, the pain is psychological. Emotions and stress certainly influence pain, but the existence of a psychological layer does not erase the biological layer. They are teammates. Healing usually accelerates when we treat them together. Pelvic floor therapy for the body, nervous system regulation for the mind, practical adjustments for the relationship. Here are the red flag combinations I never want you to ignore. Severe pelvic pain with fever, foul discharge, or heavy bleeding needs prompt evaluation. Pain with a possible pregnancy, especially if you feel dizzy, faint, or have shoulder tip pain, is an emergency. Heavy or recurrent bleeding after sex, especially after menopause, should be assessed soon. Rapidly worsening penile curvature with painful erections deserves a urology visit. Feverish pelvic or perineal pain with difficulty urinating should be seen promptly to rule out a prostate or urinary tract emergency. When in doubt, go in. Your future self will thank you. So what can you start today, safely, while you arrange care? Begin with a safety reset. Avoid any activity that reliably produces pain. Intimacy does not have to mean penetration. Remove the trigger while you create a plan. Next, support your tissues. If dryness is present, choose a simple, unscented lubricant. Water-based if you like easy cleanup. Silicone-based if you need longer glide. Consider a daily vulvar or vaginal moisturizer if you're in perimenopause or postmenopause. Avoid fragrance soaps, scrubs, deodorizing wipes, and anything that stings. Warm water and gentle cleansers are enough. If anything tingles or burns on the skin, stop using it. Layer in breath-led pelvic relaxation. Lie comfortably with your knees supported. Place one hand on your belly, one on your heart. Inhale slowly through your nose and imagine your pelvic floor dropping like the canopy of a parachute, wide, soft, downward. Exhale and let your jaw unclench. Jaw, diaphragm, and pelvic floor are neurologically linked. Relaxing one helps the others soften. 2 minutes, twice a day, begins to shift the baseline from guarded to receptive. If you suspect pelvic floor tension, seek a pelvic floor physical therapist. The techniques are gentle, respectful, and effective. Map your own pain so you can clearly describe it. With clean hands and plenty of lubricant, use a mirror and a fingertip or cotton swab to gently touch different areas at the entrance. If a specific spot burns sharply while surrounding skin feels normal, that distinction helps your clinician target therapy. If deep pressure reproduces your pain, that points in a different direction. You are not trying to provoke, you're trying to learn your pattern without judgment. If hormone-related tissue changes are part of your story, common after menopause in the postpartum period, and in certain medication contexts, bring that information to your clinician. Local therapies can restore tissue elasticity, increase blood flow, and dramatically improve comfort. These options act largely where they are applied and can be tailored to your risk profile and preferences. If you are diagnosed with an infection, complete the full treatment. Ask what symptoms should improve and by when, and schedule follow-up if they don't. If your partner needs evaluation to avoid ping-pong reinfection, make that part of the plan. If your clinician suspects non-infectious pelvic pain, agree on a next step: pelvic floor therapy, topical care for the vestibule, bladder calming strategies, or investigation for endometriosis or other conditions. Now let's talk about communication, because your healing happens faster when your relationships are safe. Tell your partner, "My body is asking for a reset. I want closeness, and I'm prioritizing comfort first." Invite their collaboration. Explore intimacy that stays away from the pain. Cuddling, massage, mutual touch that feels good, shared fantasies without penetration, baths, slow dancing, deep eye contact, laughter. Pleasure is not a narrow definition, it is a wide landscape. When you reintroduce penetration, start shallow, use abundant lubrication, choose positions where you control depth and speed, and check in often. Pain is a stop sign, not a dare. For those recovering from childbirth or surgery, know that scars are living tissue. They can be hydrated, mobilized, and coaxed into pliability over time. Gentle, guided techniques, sometimes taught by pelvic floor therapists, can ease tightness and restore comfort. If you're not ready for direct touch, that's okay. Begin with breath, safety, and patience. For men or people with a prostate dealing with pelvic pain, please hear this. You are not alone, and your pain is not a reflection of strength or masculinity. Prostatitis and pelvic floor tension can create a loop of fear, guarding, and pain that improves with a combination of medical care, pelvic floor therapy, and stress reduction strategies. If erections are painful or curvature is changing, bring it up early. It is far easier to intervene before a problem becomes entrenched. Your sexual health is part of your overall health. For trans and non-binary people, your plan should honor your body, your goals, and your treatments. Hormone regimens and surgeries influence tissue, lubrication, elasticity, and nerve sensitivity. Pelvic floor therapy and tissue support are adaptable to you. Ask for affirming, trauma-informed care. You deserve it. For people with disabilities that affect positioning, sensation, or muscle control, an occupational or physical therapist can help you experiment with supportive cushions, wedges, and positions that protect joints and nerves while enabling pleasure and closeness. Comfort is a design problem we can solve together. Let's step back and look at the biology of the pain cycle. Pain decreases arousal. Lower arousal increases friction. Friction increases pain. Anticipatory fear teaches muscles to brace earlier, so the next time you hurt sooner. The way out is not gritting your teeth. It is interrupting the loop at multiple points. Improve tissue, glide, and hydration. Teach the pelvic floor to release. Calm the nervous system's alarm, and rebuild experiences of safe touch that your body can celebrate rather than endure. Progress is often layered and surprisingly hopeful. When you see a clinician, bring a short script so you feel confident. You might say, "I'm experiencing pain with sex that feels like burning at the entrance," or "deep cramping with penetration. It started 3 months ago. It happens every time. It improves with rest, but not with lubrication. I also noticed spotting afterward," or "urinary burning the next day." Then ask for a plan. "I'd like to rule out infection, consider whether my pelvic floor is tight, and discuss treatments for tissue sensitivity or dryness. If an exam is recommended, request that it be slow, narrated, and stop anytime. You are allowed to say no at any point. Your consent is an ongoing conversation, not a signature you hand over. I want to offer a simple 7-day starter plan you can adapt. Day 1, pause painful activities and start breath-led pelvic drops twice daily. Day 2, upgrade your environment. Choose an unscented lubricant and, if needed, a daily moisturizer. Remove irritants from your routine. Day 3, talk with your partner and agree on pain-free forms of intimacy for now. Day 4, map your pain gently so you can describe it. Day 5, schedule professional care and, if relevant, request a pelvic floor therapy referral. Day 6, discuss tissue support options if you're in perimenopause, postmenopause, postpartum, or on medications that reduce lubrication. Day 7, review what helped, what hurt, and what questions you'll bring to your appointment. This is not a finish line, it's a foundation. Partners, your role is powerful. Receive your loved one's pain as real. Listen without immediately fixing. Ask, what would help you feel safe right now? Celebrate small wins, a moment of comfort, a position that felt better, laughter returning to the bedroom. Pressure and timelines make bodies brace. Patience and care help them soften. For survivors of sexual assault or medical trauma, I see you. It is common for the pelvic floor to clamp and for exams or intimacy to feel frightening. You can request a chaperone, ask your clinician to explain each step before it happens, keep your clothes on as much as possible, and stop the visit at any time. Trauma-informed therapists can help your nervous system unlearn the constant alarm. Your boundaries are not obstacles to care. They are the path to it. If you're wondering how long it takes to feel better, the honest answer is that it depends on cause, on how long your body has been guarding, and on life context. Some people feel immediate relief when an infection is treated or when local tissue support begins. Others notice gradual improvement as the pelvic floor learns new patterns. Most people improve in a stepped, non-linear way. Better days and harder days, with the line drifting upward over weeks and months. Expect progress to look like a mosaic, not a straight arrow. Keep what works, discard what doesn't, and refine your plan with your care team. As we close, I want to return to the sentence we started with. Sex should not hurt. If your body has been speaking in the language of pain, it was not betraying you. It was signaling a need for gentler attention, a different technique, a therapeutic step, or a medical evaluation. You do not have to choose between intimacy and comfort. With knowledge, consent, and care, you can have both. You can invite your muscles to soften, you can nourish your tissues, you can regulate your nervous system, and you can ask for the care you deserve. Kind, evidence-based, and respectful. If you recognize yourself in any of the warning signs we discussed, take action. If you have severe pain with fever, foul discharge, or heavy bleeding, seek care promptly. If there's any chance of pregnancy with pain and dizziness, go now. If you have bleeding after sex, especially after menopause, schedule evaluation. If you notice painful erections with increasing curvature, talk to a urologist early. If your pelvic floor feels like it's stuck in on, reach out for pelvic floor therapy. And if you've been told to just relax, I give you permission to find a clinician who listens better. Your pain is real. Your comfort is possible. Your story is still being written. I'm Dr. Catherin Harris. Save this message for the days you need reassurance. Share it with someone who needs to hear that pain is not a price of love. And remember, the goal is not to go back to ignoring your body. The goal is to move forward with a relationship to your body that is wiser, calmer, and kinder than before. Pain was the messenger. You are the healer.